Good day, everyone. Today we're diving into the weighty issue of obesity among middle-aged women in Nevada's food desert. It's a topic that's hard to digest at first, but with a well-rounded intervention and a sprinkle of behavioral change theories, I hope to show you how we can turn this challenge into a healthier, lighter future. Let's get started. Obesity is a significant public health issue in Nevada. With the state ranked 11th in the nation for obesity rates, middle-aged women, particularly those between the ages 35 to 64, are among the most affected, and they face unique health risks such as increased chances of cardiovascular disease, type 2 diabetes, and complications related to menopause. The situation is especially challenging for those living in Nevada's food deserts, areas where access to affordable, nutritious food is limited. Here, many women rely on convenience stores and fast food as primary food sources, contributing to unhealthy dietary patterns and making it even harder to manage weight. In those food deserts, the lack of grocery stores offering fresh produce forces residents to make difficult choices, often prioritizing cheap, high-calorie options over healthier ones. This issue is compounded by socioeconomic factors such as low income, limited healthcare access, and environmental barriers, all of which limit opportunities for a healthy lifestyle. In Nevada, obesity among middle-aged women have reached concerning levels. Approximately 32% of women in the states are classified as obese, with many residing in urban and rural food deserts, where access to healthy food is limited. Middle-aged women, aged 35 to 64, are especially vulnerable due to factors such as menopause, slower metabolism, and the unique demands of life stages, which increase their risk for obesity-related health issues. A key contributing factor is socioeconomic disparity. Many women in this demographic live on limited incomes, which restrict their ability to afford healthier foods. Instead, they often turn to cheaper, calorie-dense options from convenience stores or fast food outlets. Additionally, environmental challenges such as lack of safe recreational spaces further limit their opportunities for physical activity. To effectively address obesity among middle-aged women in Nevada's food deserts, the intervention is grounded in three key behavior change theories. First, the trans-theoretical model, or TTM, which focuses on the stages of change. This model recognizes that people are at different readiness levels for change, from pre-contemplation to maintenance. By tailoring support based on each woman's stage, we can guide them through gradual, sustainable lifestyle shifts, whether they're just beginning to consider healthy changes or actively maintaining new habits. Next, we have social cognitive theory, which emphasizes observational learning and self-efficacy. In this context, local role models, women who've successfully made healthier lifestyle changes, can play a vital role. By observing peers engaging in healthy behaviors such as cooking nutritious meals or participating in exercise, women in food deserts can feel more empowered and confident that they too can make these changes. Finally, the health belief model, addressing perceived successibility and benefits. This model helps us understand that people are more likely to take action if they feel personally at risk. And this intervention will increase awareness of obese-related health risks, such as heart disease and diabetes, to highlight the importance of prevention action. The intervention aims to reduce obesity rates among middle-aged women living in Nevada's food deserts through a comprehensive multi-level approach. This approach is crucial because obesity is influenced by a complex mix of individual, social, environmental, and policy-related factors that all needed to be addressed for sustainable change. At the individual level, we focus on empowering women with knowledge and skills to make healthier choices. Through workshops on nutrition and physical activity, we aim to increase their self-efficacy and provide practical tools they can use in their daily lives, even with limited resources. On the interpersonal level, we leverage the power of social support. Family members, friends, and peer groups within the community play a big role in encouraging and maintaining healthy behaviors. By fostering social networks and involving role models, we create a social support system that makes it easier for women to stick to new habits. At the community level, we address structural issues in the food desert environment. Initiatives such as community gardens and mobile food markets can help improve access to fresh fruits and vegetables. These community resources empowers residents to have better food options and reduce their reliance on high-calorie processed foods. Finally, on the policy level, we advocate for change that improve long-term access to healthy options. This includes policies that support the development of grocery stores in underserved areas and improve recreational space for physical activity. By advocating for these systemic changes, we create an environment that support healthy lifestyles for future generations. The logic model is a key tool in our intervention design, serving as a roadmap that outlines the pathway from resources and activities to the intended outcomes. It allows us to clearly visualize how each component of the intervention contributes to reducing obesity among middle-aged women in Nevada's food deserts. At its core, the logic model starts with inputs. These are the resources required for the program, including funding, partnership, educational materials, and community support. These inputs enable us to carry out a range of planned activities that directly address obesity in these demographics, such as workshops on healthy eating and exercise, community gardens, and mobile food markets. These activities then lead to measurable outputs, such as the number of workshops conducted, community gardens established, and participants reached. Outputs provide a tangible way to track progress and ensure that each part of the intervention is functioning as intended. Beyond immediate outputs, we aim for short-term outcomes, such as increased awareness about healthy food choices and improved confidence in making dietary changes. Over time, we expect to see intermediate outcomes, such as higher rates of physical activity, healthier food purchases, and stronger community support networks. Ultimately, the logic model guides us towards our long-term goals, which include a reduction in obesity rates and improved overall health for middle-aged women in these food deserts. By mapping out each step, the logic model helps us monitor, evaluate, and refine the program, ensuring that all elements are aligned with achieving our main goals of a healthier community. The intervention relies on a range of essential inputs or resources that make it possible to address obesity among middle-aged women in Nevada's food deserts effectively. First, funding is crucial to cover the cost of educational material, staff, and resources for activities such as workshops, community gardens, and mobile food markets. Funding also supports outreach efforts to ensure we reach as many women in these areas as possible. Partnerships are another vital resource, especially collaborations with local organizations, healthcare providers, and community groups. These partnerships expand our reach and enable us to share resources, tap into local expertise, and create a sense of community ownership over the program. For example, local leaders and community role models can help us encourage participation and build trust within the target demographics. Educational materials form the background of our program's content. These include guides on nutrition, recipes that use affordable and accessible ingredients, and exercise routines that don't require gym equipment. By providing practical, user-friendly materials, we empower women to make healthier choices within the limitations they face in food deserts. Community support is also essential, as it helps to foster a supportive environment where individuals are encouraged to stick to new, healthier habits. This support could come from family members, friends, or even peer groups formed within the program, enhancing participants' motivation and accountability. Finally, the involvement of healthcare professionals and access to SNAP benefits adds another layer of support. Healthcare providers can offer screening, advice, and monitoring to track participants' health improvements, while SNAP benefits help make nutritious food more affordable. The intervention input will help conduct workshop on nutrition and physical activities. These workshops are aimed at educating participants on topics such as balanced diets, portion control, and understanding food labels. For physical activity, we'll focus on exercise that can be done at home or in local community spaces, making it easy for participants to stay active without needing access to gyms. Next, we're introducing community gardens and mobile food markets to directly tackle the food access issue in these deserts. Community gardens allow participants to grow their own fresh produce, promoting self-sufficiency and improving access to fruits and vegetables. Additionally, mobile food markets will bring affordable, nutritious foods closer to residents, helping them overcome the challenges of limited grocery stores in their neighborhoods. Another key component is skill building sessions where participants can learn practical skills like meal planning, cooking healthy meals on a budget, and incorporating physical activities into their daily routines. These sessions are designed to build confidence and make healthy living feel manageable, even on a tight budget. Finally, peer support groups offer a invaluable layer of social reinforcement. These groups create a supportive environment where women can share their challenges, celebrate their progress, and encourage one another. By building a sense of community, we increase each participant's motivation and accountability, making it easier to maintain new habits. The intervention outputs will provide measurable, immediate results. We'll look at the number of workshops conducted and participants engaged. By tracking these metrics, we can gauge the level of community interest and involvement in our program. Each workshop on nutrition and physical activities offer an opportunity for participants to gain valuable information and skills, and a higher number of attendees signal growing awareness and engagement within the community. Next, we'll measure the establishment of community gardens. These gardens are a tangible output of our initiative, our intervention, as each new garden creates representative improved access to fresh, healthy produce for the women involved. By tracking the number of gardens established and the participants in each, we can access the reach and sustainability of our food access initiative. These gardens not only provide food but also foster a sense of community and shared responsibility among participants. Additionally, the number of skill building sessions completed is a crucial output, as these sessions teach participants practical skills such as meal planning and budget-friendly shopping. By counting the sessions and tracking attendance, we can ensure that our intervention is delivering consistent, hands-on guidance to empower these women to make healthier choices. The intervention's short-term outcomes may anticipate increased awareness of healthy food choices among middle-aged women in Nevada's food desert. Through nutrition workshops and educational materials, participants will gain a clearer understanding of what makes a balanced meal, how to interpret food labels, and how to choose healthier food options within their budget. This awareness is the first step towards making informed dietary changes. Another key outcome is improved self-efficacy for making healthy decisions. Self-efficacy refers to an individual's confidence in their ability to take action. Through skill-building sessions that focus on practical tools such as meal planning, cooking on a budget, and incorporating physical activity, participants will feel more capable of implementing and sustaining healthy behaviors. By developing these skills, they're better equipped to overcome obstacles, whether it's finding time for exercise or preparing affordable, nutritious meals. Finally, we aim to enhance community engagement in health initiatives by establishing community gardens, offering peer support groups, and hosting collaborative workshops. We create spaces for women actively participate in their health journey alongside others. The intervention intermediate outcomes that reflect the positive impacts of our efforts over time. One of these outcomes is an increase in healthy food purchases. As participants gain more knowledge about nutrition and build skills for budgeting and meal planning, we expect them to make more frequent purchases of fresh produce, whole grains, and lean proteins. Community gardens and mobile food markets also make these healthy options more accessible, helping to turn knowledge into action. Another critical outcome is enhanced physical activity levels. With workshops on incorporating physical activity into daily routines, combined with greater access to safe community spaces, we anticipate that participants will begin to engage more regularly in exercise. This could range from walking in local parks to participating in group exercise sessions, which are all designed to fit within their daily lives and encourage consistent movement. Finally, we aim to create strengthened community support systems by fostering peer support groups and engaging community leaders, where we're building a network of encouragement and accountability. The primary goal is a reduction in obesity rates among this demographic by addressing the root causes of limitation food access, promoting healthier dietary habits, and increasing physical activity. We aim to decrease obesity prevalence over time, leading to a healthier community. Another anticipated outcome is improved overall health and a reduced risk of chronic diseases such as cardiovascular disease, type 2 diabetes, and hypertension. By empowering participants to make consistent, healthier choices, we can help them mitigate these risks, leading to fewer health complications and an improved quality of life. This shift does not this shift not only benefits the individual but also reduces healthcare burdens from families and communities. Finally, we strive for the sustainability of healthy health behavior changes. Through the foundation, we're building with the community gardens, peer support groups, and ongoing educational resources. Participants are encouraged to maintain their healthy habits long after the program ends. Strengthened community support systems and policy level changes also contribute to this sustainability, creating an environment that continues to support healthy choices. In implementing this intervention, we recognize several barriers that participants face, particularly in food deserts. One of the biggest challenges is the social economic barrier, including the cost of healthy foods and the time constraints many middle-aged women face. Limited incomes often force these women to prioritize cheaper, high-calorie options over fresh, nutritious foods. Additionally, busy schedules and responsibilities such as work and caregiving make it difficult for them to dedicate time to preparing healthy meals or engaging in regular exercise. Another significant barrier is access to fresh food in food deserts. In these areas, grocery stores with affordable, nutritious food options are often located far away, while nearby convenience stores primarily stock processed and high-calorie items. This lack of access creates an environment where maintaining a healthy diet is a daily challenge. We also recognize cultural and community-based challenges that may affect participants' food choices and lifestyle habits. Cultural, dietary practices, or social norms around food and physical activities can influence behaviors, sometimes making it harder for individuals to adopt new habits. Additionally, some communities may have a history of limited access to healthcare or wellness resources, creating skepticism or hesitation towards new health programs. Social support and community engagement are essential elements of the intervention as they help sustain motivation and foster a sense of belonging among participants. Peer support, role models, and family involvement are a powerful tool in this effort. When individuals work together towards healthy goals, they encourage each other through challenges and celebrate success, making it easier to stay committed. Role models, especially women from the community who have successfully adopted healthier lifestyles, serve as an inspiring example. They showed that changes is achievable even in a food desert environment. Family involvement also strengthens the support network, as family members can help reinforce healthier choices at home, making dietary and lifestyle changes a shared family effort. Community gardening is another impactful strategy, serving as both an empowerment tool and a way to build social connections. By participating in a community garden, women gain hands-on experience growing their own fresh produce, which increases their access to healthy foods. This experience not only boosts their confidence in making healthy choices, but also fosters a sense of accomplishment and self-sufficiency. Gardening together shares a shared space where participants can bond over a common goal, exchange tips, and support one another, which strengthens community ties. Policy level advocacy is a vital component of the intervention as it addresses structural issues that directly impact the health of women in food deserts. One key area is advocating for the development of grocery stores in underserved areas. By supporting these policies that encourage grocery store chains and small businesses to open in food deserts, we can improve access to fresh fruits, vegetables, and other nutritious foods. This not only increases the availability of healthier options, but also reduces reliance on high-calorie processed foods from convenience stores. Another policy focuses is on enhancing safe recreational spaces. Physical activity is a crucial part of a healthy lifestyle, but many food deserts lack parks, trails, and other areas where people can exercise safely. By advocating for policy that prioritizes the development of such spaces, we're creating environments that encourage regular physical activity, which is essential for obesity prevention and overall well-being. Lastly, we're pushing for an incentive to make healthy food options more accessible and affordable. Policies that provide Subsidize or tax breaks for vendors offering fresh produce in food deserts can help lower costs for consumers, making healthier food choices viable options for low income households. Evaluation and monitoring are essential to ensure the success and continuous improvement of our intervention. To track program effectiveness, we'll implement a comprehensive method to assess each level of outcome. For example, we'll monitor attendance at workshops and participants in community gardens and mobile food markets to see how well we're engaging in the community. High attendance rates indicate strong interest and reach, while lower rates might signal the need for adjustments in scheduling our content delivery. We also measure behavior changes such as increase in health foods purchases and improvements in physical activity levels. For instance, we can use survey or self-report to track participant food purchase habits, looking for shifts towards healthy items. These metrics allow us to gauge intermediate outcomes and see if participants are incorporating what they've learned into their daily lives. Another important component is a continuous feedback loop for the program improvement. Throughout the intervention, we'll gather feedback from participants, facilitators, and community partners. This could be done through post-session surveys, focus groups, or informal check-ins. Feedback will help us identify what's working well and what we can improve. In conclusion, our multi-level intervention offers a comprehensive approach to addressing obesity among middle-aged women in Nevada's food desert. By integrating individual, interpersonal, community, and policy-level strategies, we're tackling both the personal and structural changes that make healthy living difficult in these underserved areas. This multi-layer approach ensures that each woman receives the knowledge, skills, and support needed to make lasting health changes, while the community benefits from improved access to resources. A key element of this intervention is its focus on sustainability and community involvement. Through community garden, peer support groups, and engagement with local leaders, we're building a foundation that promotes self-sufficiency and empowers participants to maintain these health behaviors over the long term. By embedding these supports within the community, we foster a culture of health that extends beyond the individual, influencing families and future generations. Ultimately, we anticipate that this intervention will lead to a reduction in obesity rates and significant improvements in health outcomes for the high-risk demographics. Beyond physical health, these changes can enhance overall quality of life, reduce healthcare costs, and build stronger, more resilient communities.